Assalamualaikum बच्चों, let's discuss chapter 34 of Cadson. It is the part of CVS and blood according to UH's curriculum, and you can expect MCQs as well as SCQ from this chapter. This chapter has three parts. The one is the anticoagulant itself. So the drug that is used to prevent coagulation in the body, like in the situation of MI or stroke. So these drugs include the first one is the heparin. Heparin, how does it act? It actually activate or accelerate the activity of antithrombin 3. Antithrombin 3 is present endogenously, and it actually degrade factor 2, 9 and 10. So heparin accelerates its action up to 1000 fold and degrade 1000 fold factor 2, 9 and 10. So the heparin is available as high molecular weight, also called as unfractionated heparin, low molecular weight heparin like enoxaparin, dalteparin and tinzaparin. Pentasaccharide active part of heparin is also available, and the name of it is fondaparinux. Adverse effects of heparin include mineralocorticoid deficiency, reversible alopecia, and it can also causes the most dangerous adverse effect is heparin-induced thrombocytopenia, that is also called as HIT. It also causes osteoporosis that can lead to fracture in females. Heparin is monitored through PTT, partial thromboplastin time, and antidote of heparin is protamine, that is a chemical antagonist of heparin, and the chemical antagonist is the drug that itself bind with the drug and chemically destabilize it. Protamine is a orphan drug, and for your interest, for your integration, protamine is the same compound that is the part of NPH insulin, neutral protamine hydrone. So heparin is also part of NPH, and it is also a chemical antagonist of heparin. Other drug is warfarin. Heparin is basically given through parenteral route, subcutaneous route, or IV routes, but it is not recommended to intramuscular route because of formation of hematoma. Warfarin is an oral drug. Warfarin is a drug that is 99% orally available. Bioavailability is 99% orally. Warfarin is abbreviation of Visconian Alumni Research Foundation. Okay, warfarin basically causes inhibition of gamma carboxylation of factor 2, 7, 9, 10 and protein CS. So it inhibits the synthesis of in liver 2, 7, 9, 10 C and S. Additionally, it also inhibits the reduction of vitamin K. Vitamin K is active in the reduced form. So it has two mechanisms. As it inhibits the synthesis of enzymes, and the factor 7 is the one that has the shortest half life in the body. So already synthesized clotting factors will be available in the body, and so its action, its onset will after the intake 6 hours after the intake of the drug. So due to its delayed onset plus protein C degradation lead to hypercoagulable state. These are the two reasons, delayed onset and hypercoagulable state due to protein C degradation. Initially we are forced to give heparin with warfarin. Warfarin is monitored through PT prothrombin time, and more advanced form of prothrombin time is INR, PT of patient over patient PT of lab, and normally it is 1, but in the patient who is taking warfarin we expect from 2 to 3. Basically, PT is different from one lab to other lab, and because they use different reagent. Adverse effects of warfarin include teratogenicity, as it causes hypercoagulable state. So you can expect breast infarction or GI bleed or infarction. So warfarin also has a lot of drug-drug interaction that make it is not a very suitable drug nowadays. But for outpatient department, still warfarin is one of the choice, and heparin, as it is a subcutaneous drug, you can't prescribe in outpatient department. So heparin is used in inpatient. And warfarin drug interaction at the drug that increase prothrombin time when warfarin is being used. These are the drugs that actually facilitate warfarin activity and increase warfarin within the body, and increase prothrombin time mean it increase anticoagulant state of the body that can be toxic for the body. So the drugs that pharmacokinetically increase prothrombin time and increase warfarin activity, these are the sulfonamide and phenylbutazone. They displace warfarin from plasma protein and decrease metabolism. And same case with the amiodarone, that also increase prothrombin and increase actually the availability of warfarin. Pharmacodynamically, cephalosporins basically decrease the count of bacteria within the gut, and these bacteria causes the formation of vitamin K. So vitamin K is not available. So and now warfarin has no endogenous antagonist. So pharmacodynamically, cephalosporin facilitate warfarin, but it can be dangerous. Similarly, hyperthyroidism and hepatic disease increase the turnover of clotting factor. So less clotting factor is available, and warfarin activity will enhance. Aspirin, clopidogrel also are antiplatelets. Warfarin itself is anti-clotting factor. They are also increasing prothrombin time in the presence of warfarin. The drugs that decrease prothrombin time and actually decrease warfarin activity includes rifampin and barbiturates. These are inducers, and so these drugs will increase the metabolism of warfarin and make less available active warfarin. Similarly, cholestyramine bind with the warfarin and increase its excretion from the body. These three drugs are pharmacokinetically decrease warfarin, while pharmacodynamically diuretics make blood volume less, and so clotting factors are more available in less blood, so it causes a more clotting factor hypercoagulable state. So it pharmacodynamically decrease warfarin activity. Hypothyroidism decrease clotting factor turnover, so it also pharmacodynamically decrease warfarin activity. So these are the drugs. Interaction of warfarin, so be cautious about before using the warfarin. And the novel drugs includes oral factor 10 inhibitors. The name of the drugs are abixaban, rivaroxaban, and edoxaban. These are used in non-valvular atrial fibrillation. Direct factor 2 thrombin inhibitors are hyaluron, bavelirodin, and ergotraban and dabigatran. Dabigatran is also orally available. Rest of all factor 2 inhibitors are parenteral. The superiority of factor 10 inhibitors or direct factor 2 inhibitors are that there is no need of monitoring, like in the case of warfarin, INR, and in the case of heparin, it is PTT. But there needs no monitoring, and they are less toxic as compared to the heparin and warfarin. But inferiority of these drugs are there is no availability of antidote. Low adixanate alpha is an antidote of factor 10 inhibitor, and idarizumab is the antidote of factor 2 inhibitor is available, but it is not as commercially available as protamine or vitamin K, that is the antidote of warfarin or fresh frozen plasma. One thing I forget to tell, that fresh frozen plasma is the first choice in to reverse for the reversal of warfarin. Then comes vitamin K. If the fresh frozen plasma and vitamin K both is present in the MCQ, and the examiner is asking who is the best choice for to reverse warfarin toxicity, then your best choice option, your correct answer will be fresh frozen plasma. So it's all about anticoagulants. Then now coming the second chunk of this chapter, that is the fibrinolytics. Fibrin basically is the start of a formation of a clot. So sometimes we need the dissolution of these clot. So we use fibrinolytics. Streptokinase and urokinase are available. Tissue plasminogen activator is an endogenous substance that endogenously degrade that fibrin meshwork. So these tissue plasminogen activators are also available, and the name of these drugs are alteplase, retiplase, and tenecteplase. So we have total 5 fibrinolytics: streptokinase, urokinase, alteplase, retiplase, and tenecteplase. They use in the patients of MI, acute MI, for its fibrinolytic activity to to break the clot. One thing you have to remember that PCI, percutaneous chronic coronary intervention, is superior. Stenting is superior as compared to these pharmacologically breakage of clot, but we don't have always PCI or stenting facility, so we can go with these drugs. Sometimes we need fibrinolytic inhibitors. We need the clot that has formed in the body. It remains in the body. The two drugs that are available as a fibrinolytic inhibitor, these are tranexamic acid and aminocaproic acid. So when we need fibrinolytic inhibitors, as we need to prevent intracranial rebleeding, we need it in post-prostatectomy when we are expecting hemorrhagic cystitis. We need it in hemophilia, and it is also used in postpartum hemorrhage in gynecology department. Okay, fine. So this is the story of fibrinolytic and fibrinolytic inhibitors. Once in my paper, fibrinolytic inhibitor question has came, but unluckily I wrote a fibrinolytic inhibitor. So you have to differentiate. Streptokinase group is fibrinolytics, and aminocaproic acid and tranexamic acid is fibrinolytic inhibitors. Now the last chunk of this chapter is antiplatelets. There are four antiplatelets drug groups. The first is aspirin, that is a COX inhibitor. It irreversibly inhibits COX. So platelets has no nucleus, so they don't synthesize new COX, and they are irreversibly unable to form platelet plug. Other NSAIDs are reversible inhibitor of COX, so the platelets will resume their antiplatelet activity. So other NSAIDs can't be used as antiplatelet drugs. It is only and only aspirin that is used as antiplatelets, and its antiplatelet dosage is 75 to 300 milligram per day. ADP inhibitors are clopidogrel, ticagrelor, and prasugrel. These among these drugs, clopidogrel is commercially very used, but it has a strong drug interaction with omeprazole, a PPI. Omeprazole inhibits cytochrome CYP2C9, and it is necessary for the activation of clopidogrel, as clopidogrel is a prodrug and it needs endogenous activation. So if you use omeprazole and clopidogrel at a time, there is no clopidogrel activation, so patient will even experience MI though he is using clopidogrel. So if it is necessary to use PPI when the patient is on clopidogrel therapy, you have to go with newer PPIs like pantoprazole and rabeprazole instead of omeprazole to prevent clopidogrel therapeutic failure. And the receptor 2B3A are present on platelets, and that help to platelets to make plug with each other. These receptor inhibitors are epcizimab, eptifibatide, and tirofiban. Phosphodiesterase inhibitors are also few drugs that are used as antiplatelets, like pyridamole, that is inhibit phosphodiesterase and inhibits cyclic GMP, and silostazole, that is also a phosphodiesterase inhibitor, and ultimately these drugs also inhibit platelet plug formation. So four drug groups are antiplatelets: aspirin, ADP inhibitor, clopidogrel family, receptor 2B3A inhibitor, epcizimab family, and dipyridamole and silostazole, that are phosphodiesterase inhibitors.